I'm very happy that you've made yourself available, Dr. Auerbach. I've been a fan of your comments in the various psychology forums. You always seem to have the authoritative voice with quite a bit of gravitas given to you. That's the correct term by other psychologists. And I appreciate the opportunity to actually speak with you and get some of your opinions and thoughts on a few questions I had.
Sure.
Could you tell me just what sort of your background is and what type of psychological work you're doing now,
sure.
where the road has started and at this point reside?
I became interested first in existentialism and then in psychoanalysis as a high school student. Now, for those of us listening, those who would be listening to this, remember, it's really not a good thing necessarily if you've got a bright kid who's interested in existentialism and psychoanalysis, because that means you are attracted to the parts of life where there is struggle and tension and conflict. But that's what appealed to me about those particular ways of looking at the world. And I grew up in suburban Long Island. And if you have an interest in these things, this probably means you don't really fit in that well with everyone. Mm. And I came into college with these interests, and this was Brown University, and had to find a way at Brown University to cobble together a set of majors to keep my interest in these things alive. And when I say this, what I mean is that, and I am thankful to the psychology department at Brown University. They were a rigorous cognitive science-based department, and they taught me a great deal about how you'd actually research psychological topics, how you would do good experimental design, and how you would get your thinking much more rigorous than many of the things that you might find in reading the Freudian text, where there are assertions that are made that either A, are false, or B, can't possibly be true, or C, in any case, are based on a handful of cases and not adequately researched for all the brilliance that's in the text. So I had to find a way to keep these interests alive, given a psychology department that wasn't terribly interested in it. And so my other major is in European history. And that way I could read a great deal in Central European intellectual history. And the other reason for doing a history major is, and this is the strange thing about much of psychology, it is about the abstract mind, though behaviorists would say there is no such thing as that, or it's irrelevant, one of the two. Radical behaviorists would say that. But it's about the abstract mind, or if it's not about that, it's about behavior, but it's not about people. And much of it is not about people. Now, when I say that, this has changed a great deal over the now decades that I've been in the field. But when I started in this, when I was at Brown University in the late 1970s, the branches of psychology that were about people, which are primarily psychoanalysis, humanistic psychology, existential psychology, those are trends that are looked askance at in much of the university, because these are not parts of psychology where there's a heavy reliance on empiricism and psychological research. Now, I happen to think that you can use psychological research techniques in these areas, and that we can get to that. But that's what I did as a college student. And then I went to the SUNY Buffalo, State University of New York at Buffalo, to get my degree, my PhD in clinical psychology. And I'll pause there so you can follow up. But
the perception at that time was that those areas were soft or lacking research, or far almost discreditable because of the lack of rigor. Mm-hmm. What was that actually true? And is it true now that the psychoanalytic literature is based on literary or kind of textual or historical style of thinking rather than rigorous scientific studies? First, I'd say that you can be rigorous with hermeneutic views as well, interpretive views, literary views as well. But my honest answer about this is that the vast majority of the psychoanalytic literature
does not involve the kinds of things that I would think of as adequate scientific research. It involves in-depth case studies from which you can learn a great deal, and they are instructive, but and they can give you excellent heuristic ideas for how you might think in depth about another human being and what you might do in the immediate moment when you're with a patient or client, because eventually it will come down to that. But it would be hard to get generalizable knowledge from many of these case studies. Now, Freud was an excellent scientist in the sense that he was always willing to revise theories on the basis of new information and to decide a previous theory had been false and a new one should replace it.
Okay.
So that's the case. But if you were to try to use the evidentiary base in his writings to prove the theories, you'd have a hard time.
Okay.
And I was trained by people, first Joseph Masling at State University of New York at Buffalo as a graduate student, and then Sidney Blatt when I became a research assistant with him at Yale, by people who had with them a very strong research ethic, an idea that, yes, you did learn a great deal from clinical case studies, but you really did have to find a way to make this much more generalizable such that people outside of the psychoanalytic fold could read it and think, yeah, there's something to this beyond, hey, well, that's a fascinating case study. So that's my background.
Okay. Okay.
And I've got a poodle who's in here visiting me. So if periodically you hear noise in the background,
Okay.
or a gray poodle appears on the screen, you'll know what's going on.
Okay. Okay. Thanks for the warning.
Welcome to well, we're deep into the COVID age.
So the status now of what would you call it? Neo-Freudianism or modern psychoanalytic theory?
Yeah. So that's
more research-based. The original psychoanalytic texts are rigorous from, I guess, to use your term, a hermeneutic or sort of the scientific style Freud had, if not actually doing experiments, but he had a sort of rigorous style of approaching material and replacing it if necessary.
Yeah.
What is the status? Okay.
Yeah. What's the status now? Or
what's the status now? What is the area itself called and exploring?
Okay, so that's another interesting question. And much of the psychoanalytic world is not involved in research. Probably most of it, because most of these people are clinicians. They are workaday psychotherapists, analysts, just trying to sit with their patients and think of a better way through. But to say that that's most of the field is also, to some extent, inaccurate. There is a fairly large group of psychoanalytic researchers. There's a large listserv for those of us who are in that community who are interested in studies of psychoanalytic ideas, both of the general theory and of the both process and efficacy with regard to the psychotherapy. And because this is the case, there have been some dramatic changes in psychoanalysis. Within the psychoanalytic world, and it's mostly a world of clinicians, people who are simply trying to think of the best way to get their patients better. And the main emphasis is on how do I understand my patient better, and how do I understand what's happening in the room at this moment. This would be in the psychoanalytic literature called the transference countertransference relationship, and my poodle apparently agrees with this because he barked there. So, and I always come to the poodle for very good psychoanalytic advice. That all said, that's much of this world, but there's a large research community at this point. The listserv is on, I believe, 4 or 5 continents. Well, at least North America, South America, Europe, and Asia. I don't know if we have anyone in Africa. And a group of people, we've been maintaining this group for nearly 20 years.
What was your major in college that you?
So the second major was European history, and within that, I focused on Central European intellectual history.
Yeah, is that where the so-called Frankfurt School is the sort of basis for a lot of
Yeah, and that's
today's thinking.
right, and that's one of the touchstones for me, because although these were Marxists who in many ways would be considered hostile to, quote, empirical research because they're interested in critique rather than in research, they as a group were always interested in how you could integrate empirical or research
Oh,
data
interesting.
into their theories. And the prime example of this is Theodor Adorno's The Authoritarian Personality. Now, he
Sure.
didn't write any of the empirical aspects of the book. It was a collaborative book. But the idea was always that these ideas had implications that you could study. And so the Frankfurt School was always interested in that integration of, we'll call it the critical European tradition of Hegel and Kant and Marx with, we'll call it the positivistic tradition, at least in some way that you could have a dialogue, even if the idea was that, and for the Frankfurt School, the idea that everything boiled down to empirical data would be something that they would have opposed greatly. Nonetheless, they were one of my inspirations for how you might have a foot in both camps, because that's what they endeavored to do. And so one of the first studies of the empirical efficacy of psychoanalysis was the Berlin study. And I believe one of the participants in this was Erich Fromm, of the Frankfurt School. Yeah.
Yeah.
And
Became a great popularizer too.
Yeah.
Um,
Wrong on Fromm's involvement in that, but they wanted Fromm involved because he was a social psychologist.
Yeah.
And that's what his training was.
The Art of Love, I remember.
Yeah.
Yeah. That also is sort of the nexus of existentialism, I guess, France. But you said in high school, it's going back a bit, that you had a sort of interest in existentialism or Nietzscheism or sort of those dark.
No matter how brilliant he is or was, that always troubled me. So, but nonetheless, if a man's brilliant, you try to figure it out anyway. The place I've wound up mostly in terms of my thinking is with Martin Buber, part of the Jewish strand of existentialism. And his theory is different because it doesn't stress absurdity. And this speaks to where I've gotten to in life, but it speaks to the issue of relationship. And the orientation I uphold within psychoanalysis is relational. That is, that the main thing that humans are about is our capacity to connect to others. And I think this works philosophically, and I think it also works in terms of the research side. And on the research side, we call it attachment theory.
Okay. So that would be Bowlby.
Bowlby.
You're talking, okay. So does that present a comprehensive way of understanding therapy and sort of emphasizing the relational aspect of therapy?
Yeah.
It's not just limited to people who've had some issue with their bonding, but it creates a whole way of understanding the interaction of therapy. How does that? What implications does that have for the types of therapy, psychoanalysis versus cognitive behavioral therapy or EMDR?
Okay, so fair question. So my understanding of the literature is as follows. First, if we look at personality theories, the best validated personality theory is the best validated theory of human psychological development, personality development, is Bowlby's attachment theory. It doesn't mean that everything in that theory is correct, because that's never that way for any theory. What it means is there's much more research evidence in favor of it than there is in favor really of anything else. And this is not because of the efforts of clinical psychologists, this is because of the efforts of developmental psychologists.
I did not know that. Okay.
Well, okay, so that I'd have to go through and see whether there is a whole bunch of stuff going on in developmental and personality psychology departments on Aaron Beck's theory of personality. And Aaron Beck did have a theory of personality, but when you read the cognitive behavioral literature, there's almost nothing on what do we expect to be important in human life? It's all about, well, how do people develop these schemas, which attachment theory also has, but it has no particular theory that I can tell about which experiences are likely to be important in developing the underlying deep schemas that any good cognitive behavioral therapist will say that she or he is trying to modify in doing a cognitive therapy. Okay, Bowlby has this because he has a specific theory that's evolutionarily based, that is cross-species. It involves all mammalian and avian species, that both of these vertebrate, I guess they're orders, have attachment as part of, and evolutionarily separate, but nonetheless attachment is part of both of these orders within the animal kingdom. So Bowlby's theory is extremely broad that way. It's Darwinian that way, but at the same time, it enables you to set up a psychotherapy that will be about the relational basis, both the relationships that someone had outside the room and the relationships that someone will have inside the room with you, which will be called the transference and countertransference in more psychoanalytic perspective. So there's that. And then there's the evidence from the common factors evidence from, and this is best summarized by Bruce Wampold and Zach Imel in their book. And when we look at what accounts for the variance in psychotherapy outcome, we have a great deal of evidence for relational factors. Things like working alliance, empathy, the Rogerian triad, the things that in attachment theory might be called the creation of a secure base. And very little evidence for technique, for orientation, for adherence to manuals. Almost all the variances in the relationship that you set up.
Yeah, that's fascinating. All the technical skills are less important than actually being a relatable person.
Right. Now, there's a technique to that too, which is kind of weird to say, but yeah. Yeah, the idea that you come across as real and empathic will get you much further down the line than any manual will get you. And if you can't do that, your patients won't do your manual.
It's certainly like counterintuitive if you look at the across the internet at what therapists are talking about their own techniques or their own special abilities or training. Which is often technique-y, but actually the ability to form a bond or to create in therapy. And what would create that? What would be the factors that would create that? What was the phrase you used? That sense of security.
Okay, so it's called a secure base in attachment theory, and to my mind, the best account of this is still Carl Rogers. Now, Rogers overstates his case. He thinks that his three conditions are not only necessary for good psychotherapy, but sufficient.
Okay.
There are technical aspects of this, but they are necessary. They are foundational. And for him, the three are genuineness or congruence, empathy, and unconditional positive regard. And if you do those three things, then the psychotherapy will develop the legs, whatever technique you're using for it to be successful. But if your patient thinks that you're not tuned in, that you're not real, genuineness, right? That you're not tuned in, you're not real, and that you don't like him or her, well, they'll fire you quickly.
Yeah, right.
Okay.
So yeah, those are the legs. And then on top of that is the skill or the technique.
Yeah. Now,
but unless you have
there is something to that.
I imagine that would be things like consistency or warmth or the actual therapeutic envelope being unvarying, or at least creating security.
Yeah. That I think is the basis of this. And so my lineage, both Sidney Blatt and Joseph Masling were trained by Carl Rogers.
Okay.
And Sidney Blatt even referred to himself as a Rogerian psychoanalyst. That is, as far as he was concerned, the main thing he was trying to do was to understand this from the patient's point of view. And if he sees it from the patient's point of view, then he's doing what he needs to do. That person will feel understood, and that will create the safety for the person to explore his or her life, her or his life, and
Let me
change.
just ask you a technical question, sort of specific question.
Yeah.
Okay, the ability to create that underpinning of security is essential. How do you deal with clients who have a schizoid inability to attach?
Fair enough.
Someone who's,
Yeah.
okay,
Yeah. So first, I'm going to take a step back. Now, there's a reason I use the term patient, which was not a word that I liked at the beginning because it sounded too medical. But I'm, with my background, I'm a big believer in etymologies. And so I want to put this out. The word patient derives from Latin and Greek, and it means the person who bears suffering. From a Buddhist mindfulness perspective, that's all of us. The client is the person who depends upon another for protection. And while that is sometimes a therapeutic role, if you think about it, what's happened in our culture is we have so devalued the idea of patienthood that we've now taken this word client and elevated it, but really that's the word that's more about dependence. Okay. So I wanted to put that out there.
Client was introduced because patient.
By Carl Rogers.
Yeah, right. Okay.
Because he wanted a non-medical word, and I don't blame him for this. I don't blame him for this at all. But eventually eventually his theory isn't client-centered therapy, it's person-centered therapy. Because there's something wrong with client as well. Because I've come to this idea from the person who bears suffering, and that's every single human.
Okay.
So that's the first thing. Now, as for the idea of those who are schizoid or non-attached, so one way of understanding this is that the more damaged someone has been by life, the harder it is that person is going to find it to form a relationship. If someone is schizoid or someplace in the, to use that as a diagnostic label, or someplace in the borderline realm, then most of the therapeutic work will be on getting that person to develop a therapeutic relationship with you. And that may sometimes take years. Whereas for someone who's relatively intact, then they will be spending most of the time on their therapy issues and much less on the relationship with you. The more work you're doing on creating that background of safety with someone's had very serious early impairments, very serious early traumas, then you're going to need to do a lot of, I guess, Winnicott's word in the psychoanalytic literature is holding. Bowlby would be calling it the creation of a secure base. You'll be doing a lot of that, and you'll have to expect that it'll be unstable for a long time.
How about with schizophrenia, where you have someone who is very antsy about relationships?
So I've spent
same thing, I guess.
Yeah. I mean, I've spent a career in the VA, and I've spent it dealing with people with severe diagnoses, schizophrenia certainly. And what I just said certainly goes there too. And there's much more caution, because if you were to flood someone with schizophrenia with deep material, that's the kind of thing that would cause that person to come apart. To decompensate, to come apart. So you're very cautious. And so I take this approach. I mean, there are people in the analytic literature who are doing deep interpretations with people with schizophrenia. I wouldn't recommend it. I recommend that you do whatever you can to create a facilitating environment, a holding environment. And within that,
they still use the term covering versus uncovering.
Yeah. I don't think you'd be doing much of an uncovering approach with someone with schizophrenia. You might have to do this if they bring in traumatic material that is genuine, and then we say, look, we must do this cautiously. The problem is here that while this is real in your life, we don't want to do this at such a depth and so fast that it overwhelms you. I would do it something like that. Okay. I'd also throw in the following. Though there's obviously a large biological component to schizophrenia, there's good research that there is a traumatic component to it, a childhood origin traumatic component to it. or at the very least, a risk factor in coming from a family with very unstable, confusing boundaries. And so it isn't the case that this is just something you handle with medication. One, there is a psychodynamics to it, even if there's mainly something we treat with medication as a largely biological illness. And second, everything that you do that's rehabilitative with schizophrenia, how you're doing this, and here's a case where cognitive behavioral therapy is an excellent approach. Whatever you're doing, that's all psychological work. That's stuff a pill can't do. Unfortunately, our medical system is set up such that we give people with schizophrenia neuroleptic medication, and we don't spend a lot of time doing all of the psychological work that's needed that can really help that person grow. And the literature on this is very optimistic that a person with that diagnosis
That's so. Okay.
can really
Okay.
grow. But such a person really is going to have a hard time making a connection to a therapist. You have to be there as that constant object. You have to really create that background of safety, and it may take a long time.
You've had interesting experiences. I mean, from the literary to working in units with some of the most seriously ill.
Mm-hmm.
Ranges the gamut from the academic to truly in the trenches.
Yeah.
How did you segue the existential worldview into a professional role?
Yeah, great question. So this was a struggle too. The classical psychoanalytic literature stresses the importance of neutrality. That's the word that we have in the translation, which is very different from the existential mindset. Now, when I say that's the word in the translation, the actual word in Freud's text, used only once, is the German word for indifference. And I have no idea how indifference as opposed to neutrality would sound in 1915 to a largely German-speaking audience for whom the papers were written. But the idea was that you were to maintain, quote, neutrality or indifference by keeping the countertransference in check. You weren't supposed to get too involved. A modern psychoanalytic perspective would say that countertransference is as inevitable as breathing, and that there's no, quote, controlling it. There's only being aware of it and managing to find ways of expressing it in ways that are growth producing and facilitating and maintaining of the patient's dignity, as opposed to being a loose cannon because you don't understand your own needs and where you're coming from. That's the first piece. So that brings me closer, because I think that the main thing I'm doing, so there's a difference, I think, between Rogers' genuineness or congruence and existential authenticity, but I think they share a similar lineage. And my belief is that I get further with my patients by being authentic. That is, by never telling them something that I didn't try out myself first, by telling them, where the limits of my knowledge are, by telling them that sometimes I've got a genuine reaction to you and I'm struggling with it, but finding a way to do that in a way that they can hear. That's the crucial part. If you're just authentic, I'm going to put myself out there, then you're no longer acting on behalf of the patient, you're acting on behalf of yourself. The idea is to find authenticity and then put it out in a way that your patient can use.
What you say about the transference is that it's sort of something that occurs all the time.
Yeah.
I mean, not only in therapy, but I suppose in every aspect of our lives, there's some tendency to
universal process. Yeah.
Watch with your third eye, so to speak, the sort of nature of the interaction and what previous experiences you've had and how they're affecting how you're perceiving the other person, and also mirroring sort of perhaps how they are perceiving you.
So, all right. So with the understanding that it's difficult to come up with a really rigorous definition of transference, other than we'll say, that we tend to repeat in new contexts relationships that are modeled on the relationships we had in the past. I think that's maybe a better way of putting it than some of the definitions, because at least this is stated in something other than Freud's energy terms for what this is. It's more information, cognitive science kind of definition of it. I have this idea that we have two communicative systems, one of which is the verbal system, and the other is the whole variety of nonverbal and affective systems, stuff that's not really under conscious control at all. I mean, it can be brought under conscious control, and when we do that, we can get paid a lot of money in Hollywood for it. But most of the time, we cannot control it very well. And so, Theodor Reich had the phrase "the third ear," listening with the third ear. Freud had similar kinds of ideas in his writing about tuning your unconscious towards the patient's unconscious, like a receiving organ or receiving apparatus. Pretty close to a quotation. But the way I understand it is that I'm listening to what someone says, but at the same time, I'm staying with what's happening in my gut and in my body as I'm listening. Because if those two channels match, then I'm thinking the patient is saying more or less what's intended. And if they are discrepant and I'm feeling uncomfortable in my body in any particular way, then there is a second message somewhere that I need to clarify with that person. Okay, that's the warded off unconscious material.
Well, have you been able to sort of create a classification of your feelings and what the person is dealing? If you're bored, you're dealing with an obsessive. If you're anxious, you're dealing with. If you're okay.
Yeah, it's a gross kind of classification, and I make sure not to hold it too tightly, because at this point now I'm talking with someone about material that they've barely been able to put into words, if they've been able to put it into words at all. And so, but yeah, if I am anxious, then I'm assuming the person I'm with is feeling very anxious about something. If I am feeling bored and want to nod out, then I'm thinking, this person is carrying something that she or he is ashamed of. Okay. And they want to hide, so I want to hide. If I start to feel really uncomfortable in my own skin, then I'm thinking someone may be warding off some anxiety that might even be panicky. Because if I start to crawl out of my skin, then now these are my first guesses. Okay, and there's always good therapy is this understanding that what you have is a map, and you should never confuse the map for the territory. The map gets you more or less where you need to be, but then you must assume that what's actually the facts on the ground are always different from the map.
Okay, that is a great way of putting it. You have to explore the neighborhood.
Yeah,
you know.
Yeah, and you will find that whatever your first approximation was not bad, but there was always some deeper truth.
What is your perception of like technique-oriented therapies?
Some
like
of them are, go on, yeah.
CBT or CBT is most practitioners are styling themselves as CBT therapists.
So some of them are really good. Some of them are really good. And the other advantage to many of them is that never do something hard when you can do something easy first. Okay. If someone says to you, I just feel so worthless, and you say, well, do you have real evidence that you feel that way? And they say no. And so you say, well, could it be some other way of looking at it? And they buy it right away. I'm not going to have to go spend a whole bunch of time wandering around in their childhood figuring out how they're stuck. And you should always do something easy before you do something hard. So, but it's a really great day at the office, even for a cognitive behavior therapist, if someone changes a maladaptive belief very quickly. people don't, and the reason they don't is that they need those beliefs for some reason or other,
Okay.
right? So they
Okay.
can't just say, hey, you're right here. But if someone says, wow, I never thought of it that way, and they can change something quickly, that's great. There are technique-oriented therapists like EMDR, which, even though part of the work is the setup of the positive and negative beliefs or cognitions, the processing is largely nonverbal. It's a very technique-oriented thing, but it can get to unconscious aspects of the mind much more quickly than, say, having someone on the couch for a bunch of years. And sometimes, if you get someone who's really stuck, this is a great way to do it. When I started, I was a fairly rigorous and doctrinaire Freudian, with the exception that I thought Freud's views of women were totally wrong. Aside from that, that's where I was, and that there was one way to do it, and this was the right way. But given evidence that basically there are all kinds of things that work, then it's a matter of, okay, what is a way of doing it that your patient will accept? And for a lot of things, the manual is a great thing to do.
You've alluded before to like tuning in your unconscious to your patient's unconscious.
Yeah.
What is actually happening there? How is that transmitted? How is the data transmitted? Is it verbally or through the?
Well, here's one way of understanding. So remember, most of our communication is nonverbal, and much of it happens on a microsecond basis. And so I can only see globally that a patient has a very sad expression on her face or his face that I suspect makes that person feel depressed, means that person's feeling depressed. But I may pick up some deep sadness in the room via the nonverbal channel, via all the nonverbal things that patient's doing. Are
you able to do that in day-to-day life too?
In what?
In day-to-day life, pick up on that sort of.
Yeah, I mean, this stuff, fortunately, it goes into the background when I'm not in the therapy room, but it's never fully asleep. And so if I'm having a conversation with a friend and something feels strange, then my next thought is, hey, look, is there something bothering you? Something that you're having trouble telling me about?
It's a real gift.
I did not have this when I entered graduate school. When I entered graduate school, I was aware of anxiety and depression. That's about it. It was largely cut off from my emotional life. So this is an entirely developed ability that, well, developed in me sometime between age 22 and age 32, sometime over the course of a decade.
I wonder what factors allow you to develop that, or what are the factors that predispose a young psychologist to be able to learn to read those vibrations.
What factors are predisposed? I can assure you that there are predisposing constitutional factors. I probably have none of them.
Okay.
I am an extremely intellectualized guy. I live in my head most of the time. It took extensive work, both training, supervisory, and psychotherapeutic, to learn about this part of myself and to be in a place where I could have ready access to it and very quick access to it. And I have it as a constant stream now. And I did not have it at age 22 when I entered graduate school.
Interesting.
I'm the only witness. I'm the only witness to this. So if you can find a witness who contradicts me on it, fine. But as far as this witness is concerned, I did not have that ability. But by the time I was in my early 30s, I did.
So what, a new world opened up on the
yeah.
Okay.
Yeah.
Okay.
And this, I think it's really the attention to the transference and countertransference, that makes a psychodynamic clinician different from other clinicians. That is, most of us spend a great deal of our lives sorting out, why did I just have that reaction to someone? That was kind of strange. And parsing that. And most other clinicians will give lip service to this, but I'm doing it on a moment by moment basis.
Yeah. I wonder if the training in dynamic therapy has something to do with that,
Yeah, and
as
that's
well as the interest in,
that's the
yeah,
training. Yeah.
yeah. I imagine reading literature too. You're hearing the inner monologues
Yeah.
of people, starting out with plague or no exit, and then, you know, working your way up through probably hundreds of other books,
Mm.
getting an internal idea of the internal life of the writer.
Yeah.
Um, but it's interesting. I wonder if that is a sort of a developmental period, 20s or 30s. Come out of high school intellectualized, probably because, you know, high school is a fairly barren landscape for actual true relationships,
Oh,
you
yeah.
know.
Yeah.
And then I guess via supervision or having to pay attention to that, being trained to do something which we're not.
Yeah. It meant having supervisors say, so when patient said X, did you feel anything?
Yeah. Okay.
What did you feel? If you don't remember what you felt, can you reconstruct it now? And if you keep going over that and keep checking, okay, what's my reaction as I hear this? Then you get this, all of a sudden, this thing opens up and you're aware that you're actually experiencing something in the moment. Humanistic psychotherapy does a lot of this as well. What humanistic psychotherapy lacks is the kind of developmental psychology that's based in instinct or drive that psychodynamic theories have. But the therapists who were best at identifying what do I feel in the moment were often the humanistic therapists. I mean, that's Carl Rogers' whole thing. That's Fritz Perls.
Anything to do why more women are predominating in psychology?
A piece of it. One piece of this is the sociology of it. And psychology has become a woman's profession in part because women are more relationally attuned in general and on average than most men are. And so you see women gravitate to certain fields in the healthcare world, one of which is psychology, and not to others. And it's that way inside psychoanalysis too. For all of Freud's horrible views about women, it's now called the Society for, I think, Psychoanalytic Psychology and Psychotherapy. It used to be the Division of Psychoanalysis. It's a majority female division. And one piece of it is that, so yeah, we're seeing this is a field where I think women in general have an advantage over men, since most of us as men are socialized to not think about relationships and not think about emotions. So there's that piece. The other piece, at least as far as the psychoanalytic world is concerned, is that Freud's theories of gender may be wrong, but he had them.
Yes.
And if you go look at all the other major figures who are out there, you won't see much in the way of writing about gender and sexuality, despite the fact that all of our movies and popular songs are about what?
Romance.
Romance, gender, sexuality,
Yes,
right? That's
exactly.
about 90% of it right there. So obviously couldn't be that important, right? But there's a whole industry that's making a lot of money on it. And so Freud has a theory of gender. And so even though it may have been a sexist and misogynist one, it doesn't mean there can't be a new theory inside psychoanalysis or theories. And so there's a great deal of psychoanalytic feminism. There's also a great deal of psychoanalytic queer theory for the same reason.
Yeah, I mean, his early writings on homosexuality seem to me remarkably liberal for the day.
Yeah, they look horrible now, but if you go back 120 years, they're better than anyone else's. They're horrible now, or I won't call them horrible, but they're unacceptable now. But in 1900, say, or 1905, what are your choices? If someone has a same-sex sexual orientation, you're one of two things. You're either a sodomite, a sinner, or you're a homosexual, which was an advance in its own way, but that meant it was an illness. That was the triumph of medical discourse over moral discourse. And Freud's understanding was that all sexual orientations are the same internally. That is, they are all the product of psychological conflict. The only difference is that if you have a same-sex sexual orientation, then your social disadvantages are considerable.
Okay.
Okay.
That was his.
But internally, one set of
Yeah.
conflicts is no more advanced than any other set of conflicts.
Okay. The case of Schreiber, was that the one where
Schreiber, yeah.
Schreiber? Okay.
Yeah.
So it was a form of
So
reaction formation or paranoia.
he had the idea that paranoia involved attempts to ward off homosexual or same-sex
Okay.
wishes.
Okay.
Now I think that wouldn't hold up so well today, but in 1900, to have a same-sex sexual orientation was not only considered shameful but potentially criminal, and so you can see how paranoid ideas could attach themselves to that,
Yes.
to
Right.
that
Right.
particular problem.
Interesting.
But in 2022, I don't think we see that a lot.
No. No.
At least I
But
haven't
it's
in a good
interesting. He
long
at least
time. Yeah.
addressed it.
Yeah.
Some basis for discussing
Yeah.
it as a relevant area of analysis.
Yeah. And so my sense is that this is a normal variant in human life, and is to be affirmed like any other variant in human life that does not harm others. Yeah. If your behavior involves harming others, whatever it is, then I won't be behind that. But I don't see how a same-sex attraction any more than a different gender attraction makes any difference.
What did he say about the other half of libido, aggression?
Yeah, the other thing is that Freud had the idea of constitutional bisexuality, which is using his jargon that everyone had a heterosexual and homosexual side, or I prefer to say a same-sex side and an opposing sex or opposite gender side. So he had that. Now, as for Freud's theories, so Freud always had an instinctual dualism. Actually, the word that's in Freud's German is Trieb, which is better translated as drive than as instinct. And Freud knew the difference between drive and instinct. And we won't get into the translation issues involved in this. And Freud's original pairing of drives was sexuality and self-preservation, sexuality and hunger. And over time, especially as the political situation in Europe deteriorated, first with World War I and then the interwar period, and ultimately the rise of the Nazis, his idea was that no, there's an aggressive drive, or actually he thought a death drive, a drive for the organism to self-destruct.
Thanatos?
Well, so he uses specifically Todestrieb, death drive. Death drive. Thanatos is a later accretion. And so this is one of the more difficult aspects of Freud, I think. Freud was onto a very important problem. That very important problem is that humans do some incredibly destructive, violent things, and it needs to be explained. But his explanation for it, the death drive, I don't think is a very good one scientifically. But the problem is still there. The fact is that we do horribly aggressive things, we do self-destructive things, we even commit mass murder, and there's something in us that needs an explanation. So the problem is that his specific formulation of the death drive is based on his understanding of 19th century biology and physics, and doesn't fit very well in a Darwinian model, and doesn't fit well with many other things in modern science, and in a sense says that we can't do anything about this because it's just part of our drive equipment, rather than understanding that drive equipment also, and Freud would have been someone who understood this, that drive equipment also undergoes a process of maturation through experience. So I'd say that, but the basic issue and the basic problem and the fact that he understood, especially after World War I, that we can kill millions of us for no good reason.
Yeah, what's going on there?
Yeah. You gotta explain something here. So
It's interesting. He was placed between two wars. I
Yeah.
mean, a
Well,
pretty violent time.
yeah. Now,
Um,
he didn't live, I think, to see the beginning of the Second World War. He died in early 1939.
oh, okay.
So
Oh, did he? Okay.
but he had already escaped the Nazis to England,
Right, right.
and so he had every idea of what was coming. And he was facing his own mortality. He was in pain most of the time from cancer of the jaw, and so that figures into it as well. He was to lose all of his siblings in the Holocaust. They were all killed by the Nazis. He got out by virtue of his fame.
Wow. Wow.
Eventually, he was given a dosage of morphine. And that was that.